Welcome back, everyone. It is the last session of today before the kağıt game. Prof. Dr. Candan Gürses and Associate Professor Göktuğ Akyoldaş will be with us here, and we will learn more about epilepsy. Before going further, I will give the word to Orhan to moderate this session.
Hello, everyone. Today we are talking about epilepsy and its treatments. We have Professor Dr. Candan Gürses and Associated Professor Göktuğ Akyoldaş. And yes, we are starting with Professor Dr. Candan Gürses. Can, welcome.
Good afternoon. Thank you for inviting me to give this talk about epilepsy. Thank you, Orhan. Thank you, Ahmetcan. I'm delighted to see that there are so many people here interested in this subject. Also great to see people from outside the medical faculty. So, this is this title is suggested to me. My title is Abnormal Electricity in Brain, What is Epilepsy and How to Treat It. So let's start with what epilepsy is not. So first, there are many urban legends. So we should first correct them. Epilepsy patients are not possessed by genius or demons and are not mentally disturbed. And they don't need to hide themselves from people or society. Epilepsy are not contagious. So there have been extensive reports to destroy these prejudgments in the last 50 years. So there have been many famous people in history who had epilepsy. This proves that epilepsy doesn't prevent people from being a composer, from becoming a composer, writer, political leader. But in only small proportion of the patients have some intellectual disability. Except this, they have mostly normal IQ, or as you see here, a higher IQ. Your knowledge may foggy like as this picture. So I hope, my hope is the scenery will be sunny and clear by the end of the talk. First, what is seizure? And we should do some definitions. Seizure is a paroxysmal abnormal discharge at very high frequency from neurons in cerebral cortex. We can call electric storm, and you may have seen a patient having seizure, so we can call also convulsions. What are these convulsions? Convulsions are involuntary, violent, spasmodic contractions of skeletal muscles. So there are hundreds of types of seizures. Seizures occur either spontaneously or due to the triggering factors. Most patients have one type of seizure, but seizure frequency is variable. What do you mean? It is as frequent as 100 times a day, or as few as once a year, or once every 3 to 5 years. But they means patients with epilepsy generally have normal daily life. So this is important. So we don't diagnose everyone who has a seizure with epilepsy. So seizures happen in any disease. So seizures become first, because of this reason, in every patient, we should do all workup to make the differential diagnosis. After that, we can easily say the diagnosis. So if seizures become recurrent, we call it epilepsy. So classifications of epilepsies has evolved in since significantly since 1960, and each new classifications is done by correcting shortcomings in previous ones. For example, in 1981, they called idiopathic, but now we called, after getting a new classification published in 2017, we call it genetic. Previously, we called cryptogenic, but now we are saying unknown. This terminology is always changing, but we should use the newest classification. We shouldn't start the previous ones. The classifications in this classification, new classification, seizures are grouped into three groups. So focal onset, generalized, and unknown onset. So let me, as for epidemiology, 5% of population suffer a single seizure at some time. Here you can see two peaks. One is during childhood. We can see many patients, and the other peak is in elderly group. So, but everyone can epilepsy at any age. When we come to the mortality, in epilepsy patients, mortality rate is 2 to 3 times higher than the normal population. Mortality increases in the 10 years following the onset of epilepsy. And here, another phenomenon, but the important phenomenon in epilepsy is sudden unexpected death in epilepsy patient. We call it SUDEP. We don't know the mechanisms, and patients are most common, the most common ages between the 25 to 40, and seizures are not cannot be controlled, and these are always risk for SUDEP. So if the patient without having any seizure, patient with epilepsy have risk, but especially during sleep, this risk, the death may happen without having a seizure, but these patients may die suddenly, unexpectedly, and generally in sleep. Each patient assumes their seizure to be the same as the others, but it is wrong. There are hundreds types of seizures. So this is another urban legend. As for etiology, we have some subtypes. What are these? structural ones, brain tumor, infarction, hemorrhage, aneurysm, trauma. Other subtypes, genetics, infection, metabolic, immune, and unknown. The most common etiology is unknown. So, as for the subtypes of seizures, first we should check generalized seizures. We have some subtypes of generalized seizures. So what are these? Tonic-clonic seizures, typical seizure absence, atypical absence, myoclonia, tonic, clonic, atonic seizures. I'm so sorry for the technical point. I have my video is not working, but this little boy, 8 years old, while he is doing hyperventilation, first he loses his mimics, his expression is dull, and in the meantime, we have a good evidence on EEG. What is this? You see, I'll maybe explain the details in my second talk, but you see abruptly, synchronously here, you see here my mouse, and you can abruptly, synchronously activity seen on both hemispheres. So here, maybe you cannot see the montage clearly, but odd numbers indicates left, even numbers indicates right. But here, we don't need to see the right or left because all these discharges abruptly start, and during that time, he has a seizure. So this seizure has no postictal sign, and when we see this EEG, so we call this seizure typical absence seizure, and we diagnosed him as childhood absence epilepsy. This guy has myoclonic jerky movements. It's a kind of abruptly jerks. And at that time, his EEG shows again generalized abnormality on his EEG. And this is myoclonic seizure. So we can diagnose him as genetically generalized epilepsy. This guy it's a strange epilepsy. We call it reflex epilepsy. It is induced by flickering lights, and the seizure is induced by these flickering lights. So we exposed him to flickering lights. You see the box here, and while his eyes open, there's nothing on his EEG, but when he closes his eyes, he has generalized spike and wave discharges, and he has a seizure. So flickering lights, another triggering factors for seizures. As for focal seizures, we can easily say that everywhere in the cortex of the brain, such as sulcus or gyrus, can produce seizures. So you see the lobes, but the lobes is not important. Every point of the brain in the cortex can produce seizure. So here, the guy's right toe of of the right toe, some continuously moving. We call it clonic movement. So this continuity, we call it previous classifications, epilepsia partialis continua. It's, in other words, status epilepticus. So do you have any suggestion about the location of this patient? While you are watching the patient's videos, you should consider the where is the location of this seizure. Here you should think homunculus. So his right toe. So we should go to the left hemisphere and interhemispheric side. You see his seizure onset zone here, and this seizure coming from here. So while you are seeing the patient, you should localize the seizure of the patient. Yes, we have another patient. This lady feels as if there are butterflies in her stomach. And afterwards, shortly afterwards, she lost loss of consciousness, and she has some automatisms. What are these? Means doing the same thing repeatedly. And in the meantime, we record her seizures, as you see here, coming from this side. What is the place? We should call the contact F8. As I said before, even numbers indicates the right. So we can easily say that his seizures come in the right anterior temporal region. So we have a good evidence, we have a video, we have an EEG, and we can easily diagnose this patient with focal seizure, and we can, after seeing the video, we can easily say that this is typical temporal lobe epilepsy. So I didn't, maybe, do you know interictal? Maybe we can, first I have to say something about interictal. Interictal means between the seizures. So between the seizures, we can see some isolated spiking activity. This one, the previous one, this is the seizure. We can also call ictal activity, means during seizure. So this is interictal activity, EEG activity, and in my second talk, I can repeat again, but this is phase reversal. Don't worry, I'll explain in my second talk. So this is again another phase reversal. The common electrode is F7. Here, there is a good equipotentials. Where are these? F8, T4. So this is from the right side. This is from left anterior temporal. And this one is left frontal. I hope your understanding of epilepsy is as clear as this one. We should also know the triggering factor, because these triggering factors must be prevented by the patients. So we should, how can we say, we should share these triggers with our patients, and they should pay attention to these issues. what are these? Sleeplessness, missed medications, stress, anxiety, drug, alcohol, high fever, especially in infants, flashing lights, but not for all epileptic patients. There are many, but I'm only just saying some. So how do we treat the epilepsy? So the treatment of first seizure is controversial. Why? Because the studies, there are studies against and for it. So because if there is MRI and EEG are not abnormal, we don't want to treat these first seizure. And if the patient has benign syndromes, we don't need to treat. And also long periods between seizures is another not treatment, these kind of patients not to be treated. So this is important. And another important thing, we should begin one drug. Monotherapy is always preferred to polytherapy. And most of our patients, 70% of the patients are well controlled with anti-seizure drug. Only 1/3 of the patients are drug resistant, or we can call it intractable epilepsy. When, in addition to these, I would like to tell something about anti-seizure drugs. Anti-seizure drugs, how can we say, is not, it's important, and because not all anti-epileptic drugs are good for any kind of seizures. So you can give one drug, okay, this is anti-seizure drug, so this is seizure, I can give any drug what I want. But it's not like this. Why I am saying, for example, one patient come to you and say that and you diagnosed as generalized seizure. If you give carbamazepine and you can, this is wrong, this is false therapy, and this is not good patient's seizures. So I don't want to intend to memorize these old drugs. There are many drugs, but these drugs good for focal onset seizures. These drugs for the absence seizures, myoclonic seizures. In addition to choosing anti-epileptic, in addition to anti-seizure drugs choosing, but how can we say, we should pay attention choosing anti-drugs because it's a course of important to consider epilepsy seizure type, epilepsy syndrome, pharmacokinetic profile. We should think interactions, effects of reproductive cycle on both male and female side. Efficacy is important and drug administration is important. You should know the adverse effects of the drugs. That's the important thing. Gender is important. Why? Because, for example, if your patient a woman and they may have get pregnant. So how can you manage this pregnancy with epilepsy? Age is important because child and elderly have different metabolism. Comorbid, if the patient have comorbid illnesses, you should think the interactions of the drugs. So this is important while you are giving treatment. This graph shows the mechanisms of the anti-epileptic drugs. All are sodium channel blocker. These phenytoin, carbamazepine, lamotrigine, oxcarbazepine, and lokozamide. This is a big graph. Again, shows the mechanisms of the drugs. For example, calcium channel blockers and another type of calcium channel blocker, CV2A, synaptic vesicle protein, and sodium channel blocker. There are many mechanisms using for anti-seizure drug. So there are several downsides to being on polytherapy. Using more than one anti-epileptic drugs may cause toxicity, teratogenity, incompliance, aggravation of seizures, increase of depression. Last but not least, SUDEP, the risk of SUDEP, another, again, is important for us. So how can we decide to discontinue anti-seizure drugs? If the patient seizure-free in children for at least 2 years, we can slowly stopping his or her drug. For adults, the duration is 3 to 4 years. If there is a previous unsuccessful attempts, we should pay attention, not stop drugs. For example, in 2 years, in 4 years, maybe you should lasting it 2 years, or it depends on his or her EEG, because if his EEG is still active but he has no seizure, you should think not stopping the drugs. And here another group, if your patient has been diagnosed as genetically generalized epilepsy, except JME means juvenile myoclonic epilepsy. This is, you should, after seizure freedom, maybe 6 to 8 years after, you should think the stopping the drugs. So there are some differences between the epilepsy group, seizure type of the groups. So beyond the treatment, patients should pay attention these subgroups. So what are these? They don't miss sleep, meal. They avoid dangerous sports. They can swim with one of friends or one of the friends and the relatives. They cannot drive. They cannot drink alcohol. Whenever use a drug, the patient should ask drug interactions, and can pregnant, but should ask doctor before pregnancy, because we have to arrange her drug, and we should give folic acid before the pregnancy. This is details for you now, but it's important to know. First aid for seizure, we should, the patients should, not the patient, the caregivers or friends, stay calm, track time, and don't strain the person, but help them avoid hazards, keep people, the patient, safe. So until the person is full aware, help reorient them. And if the seizure lasts more than 5 minutes, or if it is not unknown whether the person has had prior seizures, please call the ambulance. In the meantime, you should pay attention: airway, breathing, and circulation. Place something soft under their head, protect head, move anything hard or sharp out of the way, and losing the tight neck wear, remove glasses, turn person one side, just to prevent vomiting and aspiration, the vomiting. And description is important for us. Doctors always need this description, so take notes, and not to try to stop the contractions, because you can break the bones during this stopping. And don't put anything in the person's mouth except for something soft, because to prevent the tongue biting. And don't try to hold down, and again, and don't attempt to give oral anti-seizure drugs or food. And here, another thing, making the patient smell, smelling onion. This is a really useless thing. Please don't do it. This is another urban legend. So it is important to know that a person has epilepsy, so that during a seizure, it will be possible to help them. Yes, thank you very much for your attention.
Thank you very much, Candan Hocam. It was an amazing, wonderful presentation. Now we will continue with Dr. Göktuğ.
Hello, everyone. Could you give me 5 minutes for preparing my presentation, because there is some problems on my PowerPoint program. So please, could you give me 5 minutes for preparing?
Sure.
Göktuğ, do you want me to continue with my second talk?
Yes, yes. If you
prefer, have,
I will be very glad to continue with your second talk.
Okay.
Then after that, I can present my presentation, because there is some problems about my PowerPoint software.
Okay.
Thank you.
Okay. Have a good luck. 1 second. Not this one. So this is EEG workshop. I have designed this workshop upon your request, but I worry about its content, because it's a little bit boring for you. Let's see. So EEG is for electroencephalography. It's really it is an invaluable tool. These biological potentials are of such small magnitude, so we need to magnify these amplitude, and we need amplification. So amplification is required to display these signals. We need filters to show our brain activity in a good position. So we should also aware of we should be aware of artifacts to prevent them. So electrode placement 10 to 20 system is used by all labs. These 10 to 20 system is a system indicates 10 to 20% ratios of one another electrodes on placing the electrodes. So I'll show the illustration in few seconds. As I said before, even numbers indicate right side, odd numbers indicate the left side. Lowercase z is midline, lower numbers are anterior, higher numbers are posterior. So all electrodes, two characters, one letter, one number. T5 means temporal, 5 odd numbers, so left temporal. But where? Is it anterior or posterior? Of course, it's a posterior. So we can say this is posterior left temporal electrodes. So this is we should measure not only one time, maybe several times all these. Otherwise, we cannot place the electrodes on the scalp. So everyone has not the same head circumference. So we should measure and calculate these and then place the electrodes. Montage is another important thing because can easily imagine and remember while reading EEG. So we have used two types of montage. One is bipolar, the other one is reference. Bipolar means one electrode is connected to the next one. Next electrode means to form a series of connected electrodes. I showed the differences. And the reference electrode means you should connect what I mean. All electrodes connect only one electrode. I'll tell the differences showing the montage in few seconds. There are preparations that need to be done on the part of the patient. Patient should be patient needs to be full stomach. Hair must be clean. There is no hair gel, nothing. And a patient must take their drugs in usual order. And he or she should be wearing comfortable clothes for long-term EEG or sleep EEG monitoring. And this is patient acceptance form should be filled out by technician. And this is as for preparation for the technician, technician should introduce him or herself and should give some explanation about the recording. But technician also should also give this information about the EEG electrodes and the duration of the recording. But this is important. Explain that no electric current, no radiation, no drugs will be administered during the recording. This is silly questions, but still are asked by our patients. So another thing technicians should mention, this is not intended to test IQ. Technicians should also mention in patient room, there are cameras here, and the patient shouldn't cover their bodies throughout the recording to observe the details of the seizure semiology. And patient caregivers shouldn't interfere during the seizure. So this is important. Another important thing, the duration. Why we are doing 9 minutes EEG, at least 9 minutes, because we would like to see at least one sleep cycle. So in adults, one sleep cycle, duration of the sleep cycle is 9 minutes. Technician must ask the patient to close and to open their eyes at least 6 to 8 times. This is important. Otherwise, you cannot diagnose the patient, the details of the syndromes. So let me say some terminology of seizure, as I said before. So I skipped one, epilepsy, skip. Aura. Aura is a subjective sensation that can immediately precede a seizure. Ictal means during seizure, interictal, as I said before, between seizure, postictal, after seizure. So brain electrical activities is affected by various factors. There are environmental factors, genome, and as you see here, there are interactions between these factors. So here, EEG waves are formed under the influence of physiological, non-physiological activity in addition to brain activity. So we should, while we are recording, we should eliminate these physiological and non-physiological activity because they are not coming from the brain. So this elimination is important to get these data. Alpha waves, the most important waves in our brain, because seen in posterior regions, and it is blocked when opening the eyes. So it is like a fingerprints, don't change throughout the life. So should be the same in both hemispheres, and if there is a difference more than 1 Hertz, it means that is abnormal. So low frequency hemisphere is again abnormal. So first I have to tell about the montage. This is bipolar montage. What we said first, the electrode contact with the other, and you see this connection, and this is left parasagittal region, this is right parasagittal region, this is left temporal region, and this is right temporal region. His eyes closed, and you see these alpha waves. This is the duration of these 2 thick lines is 1 second, and during this 1 second, you should count the peak of the waves. So if you count, you can easily see 9 to 10 Hertz alpha waves. So afterwards, he or she opens eyes, and this alpha vanished, disappeared. You see, it's a kind of blocking the alpha. So this is, there is no alpha. this is again bipolar montage. But what we see, there is no eye blinking. Maybe I can show these eye blinking. You see eye blinking artifacts. This is artifact. This is also artifact, a muscle artifact. There is no eye blinking here. There is no alpha, but you see some triangles. Huh? Where are these triangles? At the posterior part of the hemispheres. Where is it? T2, T6O2, T5O1, P4O2, P3O1. We call it post. Post is short for posterior occipital sharp transients. And you know non-REM, non-rapid movement, eye movement. We have two stages. One stage is, we can divide the sleep into two stages. One is non-REM and the other one is REM. Non-REM divided into three stages and 1, 2, 3. So we see these posts during the stage 1 of non-REM sleep. Okay. So this is vertex, this one, vertex sharp waves. This is the wave anterior part of the hemisphere. You can see some spindles. Did you see? Seems like alpha. Do you agree? So these spindles and the vertex sharp waves seen in the non-REM stage 2 of sleep. So, but the term sharp in the phrase shouldn't put you off. These are the only sharp waves that are normal in humans. Don't worry. Everyone has these sharp waves. This is K complexes. You see big waves, and sometimes before, sometimes just here, see some spindles. Again, we are in the non-REM stage 2. Here, non-REM stage 2, we saw some sleep spindles. Now, we have nothing, no sleep elements, no sleep spindles, no K complexes, no vertex sharp waves, no posts. So we are in the non-REM stage 3. So this is the important stage. If we don't have this stage, we cannot refresh ourselves. As for REM, means is short for rapid eye movement. There are two important things here. One is rapid eye movement. You see the artifacts, very fast activity, eyes activity here. We see this, and the other one, atonia. This is EMG channel, and there is no muscle movement here. So if we call REM, we should pay attention these two conditions. If we have this, yes, we are now in REM. We usually dream at this stage more than 90% of the time, and it's important. So when we come to epileptic discharges, you see here spiking activity, and afterwards you see the slow waves. It's easily recognized from the background. Spike activity, the duration of the spike must be at least 70 milliseconds. Sharp waves has a duration of 70 to 200 milliseconds and is frequently associated with slow waves as this here, and may spread to the neighborhoods, and you can see isolated forms, or you can see in series of rhythmic discharges. Here we come to the polarity. Polarity, you see, if the tips of the spikes face each other, it is called as negative phase reversal. If the tips of spikes opposite here, opposite of direction, point of opposite direction, we call it positive phase reversal. Here, easily we can say this is negative phase reversal, where at C3, you see, here there's a line, empty line, because C3 and P3 shows equipotentials. What are these? We can say that C3 and P3 have the same potentials, but one is positive and the other one is negative. So we call it equipotential. So this is important because it indicates a bigger epileptogenic region. Do you remember the montage? This is reference montage. So all electrodes are connected to one electrode. Why we are doing this? Because we would like to see the amplitude of the highest amplitude of the electrodes. Here you see C3, the highest amplitude. So we can easily localize the epileptic discharges on C3, means that left central region. Again, reference montage, and easily we can say this, yes, this epileptic discharges coming from left frontal region. Here, did you see any spiking activity? Yes. Do you have any? Do you want to say anything about the location? Do you see the slow waves intermingled with this spiking activity? So if we check the electrodes, the common electrode here, O1, and O1 is, we call it left occipital region. So we should check, yes, this is not bipolar montage, but we should check with reference montage. When we put these electrodes, all electrodes are connected with CZ. So after getting this issue, so we can easily say that our epileptic discharges coming from occipital, left occipital area. So the responsible area here. But this guy's unlucky, is unlucky. Why? Because he or she has multiple foci. Why I am saying this? This is left occipital. Here, phase reversal at T3 means left temporal. You see equipotentials here, C4, P4, and here T4, phase reversal, many discharges in one page, you see. So as for generalized epileptiform abnormalities, we call it, we can see some subtypes, But I would like to show one type of generalized epileptic discharges. So this discharge seen on both hemispheres, as I said before, and mostly predominant over the anterior regions, and you can easily see the spike and wave discharges. So activation methods is also important. What kind of activations? First, to open and close eyes, another activation. Hyperventilation means inspiration slowly, expiration slowly, doing this continuously. Intermittent photic stimulation, flickering lights, the person, and the sleep. Sleep is important. Here, eye closing and eyes opening. If you do not do this eyes opening and closing at least 6 to 7, 8 times, you can miss this patient's syndrome. This is eyelid myoclonic absence epilepsy. But otherwise, you should miss this point. This is 2 minutes after beginning of hyperventilation. Here, age is important. Why I am saying so? If patient's age is below 18, this EEG is normal. But if the age is above the 18, it's abnormal. So what do you think about this patient? He's 15 years old, so still patient is below 18, so this is normal EEG, okay? So photic stimulation, intermittent photic stimulation, flickering lights to the patient at a certain distance, and you should give this instruction to open and close eyes strictly, and this is so much detail. And here you see some eye movement artifacts over the frontal regions. Did you see F, F, here, F, here, F, and there's another blinking. But now he, after closing his eyes, maybe less than 1 second, he has generalized spike and wave discharges. Here, it's important when the technicians see these discharges, he or she should stop flickering lights. Why? Because he can induce the generalized seizure. Oh my God. There is he forgot to stop this EEG photic stimulation. May God save the patient. She has no seizure. Otherwise, everything is going worse. So sleep and sleep deprivation is also another provocative factor, but all night sleep is not desirable. 2 hours earlier than usual waking hour is enough for slight sleep deprivation. Artifacts is important because we should be aware of these artifacts to prevent them. This is artifacts, and for the beginners, it seems like generalized spike and wave. Do you think so? Huh? Maybe, but this is artifact. He nodding his head and vertically, and you can see this kind of artifact. Another head fall during short nap, and you can easily see nothing happened, and this is artifact, seems like artifact, but your technician should take note on EEG. This is vessel artifact. Did you see this expanded this rhythmic activity? If you change a little bit the electrodes place, you can easily prevent this artifact. This is a 4 Hertz tremor artifact. Why I am saying this? Yes, because I count 4 to 5. What kind of tremor? Do you remember this? Maybe we can diagnose from EEG. I think he had Parkinsonism. You see, you can easily diagnose patients from EEG. So this kind of blinking artifacts. This is important because if you don't prevent this artifact, you can miss some abnormality on EEG. And after he was born, he's stopped a little bit this blinking, but maybe he forgot in few minutes, and he again blinking the activity. This is another kind of blinking. This is chewing artifacts. For the beginners, sometimes it can be missed as a generalized spike and wave discharges. This is swallowing artifact. This is hiccup artifact. This is muscle artifact. You see here some muscle movements here, here, here. Yes, this is ECG artifact. You see, we can see ECG on posterior temporal regions here and also here, both left and the right side. I can describe the physical appearance of this patient simply by looking the EEG. Is it possible? Huh? What do you think? I am magician or not? Why? Because in obese patients with short, thick necks, the pulse in the carotids expand to temporal lobes, and this causes ECG artifacts. So this is important to know these, and you cannot miss these artifacts. So this is another artifact, sweating artifact. We should prevent this artifact. This is important. First, the technician should stop the recording and makes the patient cool, and then afterwards re-record the EEG. So thank you for your attention. Do you have any questions? Please let me know.
Jam, we have a lot of questions, but first we can continue with Dr. Göktuğ.
Okay.
His presentation ready.
Hello everyone again, and let me share my screen, and I open my camera. Is there a problem about the noise, voice or screen?
No, Jam, all perfect.
Okay. Can you see the presentation?
Yes, we can see the presentation.
Okay. Okay. Hello, everyone. We will discuss today. We will discuss epilepsy surgery. First of all, I would like to thank the organizing committee for inviting me for this presentation, and I would like to thank to a special. I would say some special things for Professor Gürses. It is very important, and it's an honor for me to share a session with Professor Gürses, who is one of the most influenced epileptologists in Turkey. So thank you again for the organizing committee. We will discuss today epilepsy surgery. You know, I am Dr. Göktuğ Akyoldaş. I am working as a neurosurgeon at Koç University Hospital, Department of Neurosurgery. Sorry. Okay, and okay. I would like to start my presentation with a very important publication about success of the anti-epileptic drug regimens. As you see, 36% of the epilepsy patients are refractory for anti-epileptic drugs. So it's a very important public problem in the world. What is drug-resistant epilepsy? According to International League Against Epilepsy Commission, drug-resistant epilepsy may be defined as failure of adequate trials of two tolerated and appropriately chosen and used anti-epileptic drug schedules, whether as monotherapies or in combination, to achieve sustained seizure freedom. So what is adequate medication trial for epilepsy? Right drug, right dose, right duration, adequate black drug levels, medication not stopped due to side effects, and cooperation of the patients. The epilepsy surgery is one of the most important treatment choice for epilepsy patients. So in the medicine, among all the disease, epilepsy surgery needs lots of pre-operative workup for preparing surgery. We call test before epilepsy surgery. We divide them into phase 1 is, scalp electroencephalography, continues with the EEG, high density EEG, spatial electrodes, CT scan, MRI, PET and MRI imaging fusion, magnetoencephalography, MRS, neuropsychological tests, functional MRI, FDG, PET, SPECT, SysCom that enable us to fusion the MRI and SPECT, and VADA tests. So surgical decision making. Not all people required, this slide. Correct time for epilepsy surgery. Resective surgery is a consideration in patients with drug-resistant, uncontrolled, disabling focal epilepsy if the seizure originates from a region that can be removed with minimal risk of disabling neurologic or cognitive dysfunction. Test before epilepsy surgery. There is an order problem, so sorry. So let me correct them, and after that I will continue to my presentation. Yes, okay. Yes, test for epilepsy surgery, I mentioned before this test. And test for epilepsy surgery, I mentioned before, we divided into two phases. And phase 2 is pre-surgical evaluation for intracranial depth electrodes, subdural strip and subdural grid electrodes, and electrocorticography or intracranial electroencephalography. This test, we divide this two phase into whether they are invasive or not. Phase 1 tests are non-invasive and phase 2 tests are invasive evaluations. Surgical decision makers after this test, we have some decisions, we have some ideas for epilepsy surgery. First of all, not all people required phase 2 or 3 testing because when MRIs, PET-CT, SPECT, or another test point some epileptic zone exactly, so you don't need to process the phase 2 tests. So, but in some cases, in some patients, the WADA test show different area, the SPECT shows different area for epileptic zones, and PET-CT shows different area, and the semiology and the type of seizure point different areas. So you should proceed to phase 2 testing. I mentioned for phase 2 tests are invasive tests. So correct time for epilepsy surgery. Resective surgery is a consideration in patients with drug-resistant, uncontrolled, disabling focal epilepsy. Seizures originate from a region that can be removed with minimal risk of disabling neurologic or cognitive dysfunctions. So when we proceed to phase 2 tests, there are, as you can see, the illustration of the phase 2 tests. First of all, grid electrodes. As you can see, there is a plastic layer that contain some metal electrodes in it. So you you place these electrodes on the cortex, onto the cortex, and you get recordings from the cortex. Another option for intracranial monitoring is strip electrodes. As you can see, strip electrodes is a thin strip that contains metal electrodes, and this enables us for getting recording with the same way of the grid electrodes. And another options for intracranial monitoring that we call phase 2 tests is depth electrodes. When you place depth electrodes, you got lots of electrical activity correctly in the depth of the brain. So there are some advantages and disadvantages of this test. The main disadvantage of this test is risk ratios. First of all, when you placed strips or grips with surgical intervention, you can face minor or temporal complication rate up to 4.6%. But when you compare to strip and grid electrodes placing, the depth electrodes complication rates are very low. As you can see, major and permanent complication of the placing of the depth electrodes are 1.6%. So there are low risks of complication. So you can get more information about the epileptogenic zone when compared to strip and grid electrodes, and you can have three-dimensional information about the epileptogenic zone with depth electrodes. So depth electrodes are better than strip and grid electrodes when you compare. So I would like to mention about stereoelectroencephalography, another name of the depth electrode. The pre-operative workup, when you decide to place depth electrodes, you should have some workup studies, MRIs, and sometimes angiographies, functional MRIs, and tractographies. As you can see, this is one of our patients. Maybe Professor Gürses remember. We place lots of electrodes. This lines shows us the trajectory of the electrodes. As you can see, coronal section, sagittal section, axial section, and the 3D modeling of the depth electrode placement. We place these electrodes very precisely. So as you can see, Pre-Operative Workup, we write all the electrodes on the table and we divide them into according to their location and the colors, and we have some precise measurements for exact and correct placement. So as you can see, an operation room table that we use in the operation. So fixation of that, we fix the head with a stereotactic frame, so you can enable access to skull calvarium approximately about 360 degrees. So we use neuronavigation system for correct and exact placement of the data electrodes. As you can see on the left side, we have recently placed depth electrodes. I think there are about 8 electrodes on the right side. So we proceed to left side, and we are now preparing to placing the right side electrodes. As you can see, there is a navigation system that enable us to place electrodes precisely. So there is a targeting system. So when you use the system, it is very, very comfortable for surgeon to place electrodes correctly. So targeting precisely is like this. This is a monitor of the locked screen of the targeting phase. As you can see, maybe you can see there is a 0.1 target alignment error. So it is acceptable to the 1.0 is acceptable, but we placed our electrodes with target alignment error of 0.1. So we use surgical drill for open a hole in the brain, in the skull. And then after placing the electrodes, we perform an intraoperative CT scan to control the electrodes. And after that, we transfer to CT scan imaging to neuronavigation system, and we fuse the pre-operative and perioperative trajectories and CT scan, and after that we compare the correct placement of the electrodes. As you can see, this yellow line is our preoperative trajectory, and after the fusion of the images, as you can see, the electrodes, it's very correct and precise placement of the electrodes. As you can see, another electrodes, right and left orbital frontal electrodes that we previously placed, and then as you can see, these red lines shows the preoperative lines, and this sparkling electrodes shows us the postoperative CT scan. As you can see, we place very precisely the electrodes, and as you can see, there is an axial view plane of the CT scan and fusion of MRI. As you can see, there is a red line, and they are very precisely placed electrodes, and another one is on the right side. Can you see my mouse cursor?
We can see, hocam.
Okay. So this is the procedure of the second phase test for epilepsy for point of epileptogenic zone, and after that, the patient transferred to video EEG room, and we get recordings. We get recordings from these depth electrodes, and 24 hours, a technician observe and monitor these electrodes recordings, and we got video imaging record to have seizure types. during these recordings. So types of epilepsy surgery. There are lots of epilepsy surgery procedure. I will mention about some initial or some important procedures. The first of all, temporal lobectomy and amygdala hypocampectomy. We can perform frontal lobe resection, or we can perform parietal and occipital lobe resection, or we can perform laseronectomy for lesions. When we detect a lesion that can cause epilepsy, so we can remove this lesion and patient can be seizure-free. So multiple subvalve transaction, we can perform multiple subvalve transaction. Laser interstitial thermal therapy. Another option is anatomical or functional hemisphereotomy and hemispherectomy. We can perform corpus callosotomy or stereotactic radiosurgery or neurostimulation. First of all, the most important and most commonly performed epilepsy surgery type is temporal lobectomy and amygdala hypocampectomy. So there are two types of temporal lobectomy and amygdala hypocampectomy. First of all, you can open a temporal skull window and enter the dura, and then you can remove the anterior part of the temporal lobe, and you should, in this procedure, remove the amygdala hypocampectomy. As you can see, this red area shows temporal part of that we resect, and this dark green part shows us amygdala hippocampus, and you should remove the amygdala hippocampus. In this illustration on the right side, you see selective amygdala hypocampectomy procedure. So in this procedure, you don't need to remove the temporal lobe. Only you make an incision in the middle temporal gyrus, and after that you access and reach to amygdala and hippocampus, and then you can remove selectively amygdala and hippocampus. As you can see, there's a sample case, and maybe Professor Gürses remember. This is a 26 years old woman. So we placed depth electrodes, and we observed that the most of the seizures originate from right temporal area. So we performed right temporal lobectomy and amygdala hypocampectomy. As you can see, this is a CT scan after the operation. On the right side, you see an axial plane, and on the right temporal lobe was resected by me, and on the right side, it's belonged to same patient. The coronal section shows us the total resection of the temporal lobe of amygdala and hippocampus. So another procedure for epilepsy treatment is frontal lobectomy. When you place the depth electrodes, or if you observe, or if you detect the epileptogenic zone in the frontal lobe, we perform frontal lobectomy. As you can see, the illustration of the procedure, you can resect the frontal lobe with this green plane. So let me show you another case of us. As you can see, it is very important to document to your patients. So we have our documents for patients. As you see, this patient is a 16 years old boy. So we placed the depth electrodes, and after that, Dr. Gürses told us that the seizures originates from the frontal lobe, and after that I performed right frontal lobectomy. As you can see on the right side, the sagittal plane of postoperative CT scan. So we removed the frontal lobe with this line. There are some technical issues for this line. So if you ask me why you remove this from this limit. There are some technical issues for this. So as you can see, this is Corpus Callosum. So we reach the Corpus Callosum, and as you can see, the neighbor of the Corpus Callosum is cingulate gyrus. So we remove the anterior part of the cingulate gyrus. As you can see, you can see the cingulate gyrus. When you continue to see the continuity of the cingulate gyrus, it is going through like this. So on the right side, you can see coronal plane of the patient. As you can see, we removed the right frontal lobe with including orbitofrontal gyrus and gyrus rectus. So we go down to skull base, anterior skull base. So when we mention about surgical risk, the resective surgery, when you perform resective surgery, there are two types of complication. First of all, medical complication. Second of all, neurologic complication, and the final death. When you perform resective surgery, it is very possible to face approximately 5% 5% of major complication, or minor complication, and 1% of major complication. When you perform resective surgery, it is very possible to experience or face neurological complication in rate of 10% for minor complication and 5% for major complication, and 1.5% permanent hemiparesis. And the mortality rate of the resective surgery is 0.4%. Other palliative surgical options are vagal nerve stimulation. We don't know we do not understand the exact mechanism of the vagal nerve stimulation mechanism, but we use it more commonly in children, and it can utilize or enable 50% reduction in seizure frequency in 50% of the patients. So in some cases, we can use this vagal nerve stimulation device for reducing the seizure frequency of the patient. So another option for epilepsy surgery is multiple subpial transection. You resect you perform subpial resections for epileptogenic zones. Maybe you know what is PIA. PIA is the one of the layer of the brain meninges, central nerve system meninges. So you perform resections, skip resections for subpial cortex, reserved for important cortex which cannot be resected without high risk of neurological deficits, and generally not very effective. So we don't use commonly multiple subpial transection for the epilepsy patients. Another option for epilepsy surgery is corpus callosum. Maybe you know, I guess you know what is corpus callosum. So it's commonly performed in children with drop attacks or disabling convulsions. You can remove anterior two-third part of the corpus callosum, or complete section of the tract connection the two hemispheres of the brain. As you can see, you enter to the corpus callosum via interhemispheric approach, and when you reach the corpus callosum, you disconnect the corpus callosum and remove the anterior two-third of the corpus callosum. Hemisphereotomy is a very big operation for epilepsy surgery. There are types of hemisphereotomy. As you can see in these illustrations, types of epilepsy, types of hemisphereotomy. You can remove the posterior part of the frontal lobe and plus temporal lobe, or you can remove totally of the one of the hemispheres. But this procedure, as you guess, comes with some complications. When you remove these areas, a special motor area, it is very, the patient have hemiplegia on the opposite sides. So we perform it very rarely, and we use it for especially Sturge-Weber syndrome, hemimegaencephaly, and Rasmussen's encephalitis. The newer options in management of epilepsy are hippocampal stimulation, anterior thalamic nucleus stimulation, responsive neurostimulation, radiosurgery, and laser ablation therapy. Hippocampal stimulation, there are numbers for research. We need numbers for research requirements. Initial data has not been very promising recently, and research trials ongoing, although not in Canada. So we need some data for using hippocampal stimulation. We need more data in the literature. So responsive neurostimulation is another newer option for treatment of epilepsy. RNS administered stimulation only if triggered by seizure activity. And is investigational treatment for medically refractory current under review by FDA. As you can see, you placed a generator on the scalp. There are two components of this. There are three components of this this device. First of all, it's battery and recording device. Another one is a strip electrode, and another one is depth electrode. So you record the abnormal electrical activity, and then this device gives some electric shock or electrical activity to prevent seizure. So now we are in contact via Professor Gürses that get this device in Turkey and for use our patients. Another options for epilepsy is radiosurgery. Maybe you know it, gamma knife radiosurgery. May be useful for areas which are hard to operate, but recent trials have shown up to 65% response in temporal epilepsy. But also we need data for use radiosurgery for epilepsy patients. And last procedure or last intervention for epilepsy is MRI-guided stereotactic laser ablation therapy. In this MRI images, you see placed electrodes. It's insert from occipital lobe, and it's going through to hippocampus and amygdala. You give some electrical activity, and you perform thermal coagulation for amygdala and hippocampus. As you can see, the post-operative MRI scan after 3 months. As you can see, destruction of the hippocampus and amygdala. In the US, it is very commonly used procedure right now, but in Turkey, we don't use this procedure recently. So we need some data also for this procedure. So in conclusion, surgery may offer freedom from disabling seizures in patients who have failed antiepileptic drugs. Various tests are used to help individualize the benefits and risk of surgery on an individual basis. One must balance the risk associated with surgery with the risk of ongoing poorly controlled epilepsy, and epilepsy surgery should not be considered as a last resort for epilepsy patients. So patients discuss their condition and future prospections for his surgeon and epileptologist. So thank you for patience.
Thank you very much, Dr. Akyoldaş. It was a wonderful presentation. There are lots of questions, but we have time limitation. So I just want to ask one question for each professor. First question is for Dr. Gürses. Can a person experience seizure and not be aware of it? Can a person be an epilepsy patient and not be aware of it because the symptoms are very wide and various?
So, what is the question?
The participant ask that can a person experience seizure and not be aware of it? I mean, are there any seizure type happening before without our consciousness?
Yes, of course, we have many types of seizures without unconsciousness. We call it with the new classification awareness. Without any impairment of awareness, he or she can have seizure. And for example, she has some sensation on her left arm, and or some sparkling lights, flickering lights on the left upper vision field. So this kind of seizures, nobody understands from the outside, but the patient feel these and he or she says that I have seizures. So I can give many examples about this.
Thank you very much. And second questions for Dr. Akyoldaş. After epilepsy surgery, does patients have permanent cognitive or memory problems due to the resection of the part of the brain?
It is up to which region of the brain you removed. It is according to which region of the part of the brain you removed. So when you remove the temporal lobe on the dominant hemisphere, maybe you can have some speech problems. And if you remove the hippocampus and amygdala, patients can experience cognitive problems, especially in memory. So when you remove the frontal lobe, you can experience, or patient can experience behavioral changes and memory problems. And when you remove the occipital lobe, a patient can experience or face vision problems. So maybe Professor Gürses can tell something about this issue, because his experience are very high, and he worked together with very experienced surgeon before me. So he maybe Professor Gürses can share experience, her experience after resective surgery.
Okay, thank you for your answer, Göktuğ. Yes, we have this kind of complications, but before the surgery, we do all workup, as Göktuğ said. Pre-operatively, we are doing neuropsychological tests, psychiatric tests. So after getting these results, we can say that she or he has have disability after the surgery. So we should discuss this condition with the patients. And after discussion this, maybe sometimes she doesn't want to be surgery. So because of this reason, what is your findings? And these findings makes you worse or good. But in totally, after especially temporal surgery, yes, we have patients have some losses, but mostly we see gains. Means he again after surgery, his neuropsychological test improved. So we got these data. We have a big data now. We are writing a paper about this. This is 30 years surgery patients from Istanbul Faculty of Medicine. So this is a good data, and not always losing memory, but gaining memory also is another factor.
Thank you very much. Hocam, thank you very much for coming and your interest to our events. And lastly, we want to take a picture. I will kindly ask our participants to open their camera. Okay.
Thank you for your organization, Orhan and Ahmetcan. Thank you for your inviting us to give a speech. I'm very happy with you.
Hocam, it's a pleasure for us to seeing you and listening you.
Okay, see you. If you have no other questions.
Hocam, I'm just taking a picture. Please.
Huh? Not?
Sorry.
Okay.
I waited for everyone to open their camera. So
I
now
see.
I'm taking
I
it.
see. I thought that Orhan take it.
Okay. 1, 2, 3. Thank you again.
Thank you very much. It's last session of the day.
Please send me this photo also to us.
Of course.
Okay. Thank you. Bye-bye.
Evening.